So my name is Christophe Goossens, and I'm a program manager with Vlir EOS. What we do is actually reorganizing this community talk. It's a monthly platform that we're trying to organize every last Wednesday of the month, and where we actually ask experts from Flanders and abroad, of course, with their partners, to share their ideas, to share their expertise with a broader audience of people from NGOs, from embassies, from ministries, and also, of course, from other universities and research centers. So the idea is that we try to share ideas. We also organize this kind of meetings also to create connections, to create new connections between professors and researchers, and also any other people who are interested in this topic. Today we're going to DRC, and I'm very happy to introduce you to Professor Koen Devriendt. He's connected to the University Hospital of Leuven, and I won't take too much time because he has a very nice presentation, I must say. So please, Professor Devriendt, the floor is yours. So I suggest that we will watch this presentation, and only afterwards we will then foresee a Q&A session where the audience will be invited to ask questions. Should you have already a question, please feel free to post it in the chat so that we know exactly already what your question is, and then afterwards we can address it and we can ask the right person to come up with the answer. Professor Koen, the floor is yours.
Okay, thank you very much. Do you see the screen, my screen?
Yes, we do.
Yes, okay. So welcome everybody. Goedemorgen, good morning, bonjour. It's my pleasure to introduce to you the story of clinical and medical genetics in the Democratic Republic of Congo. And well, for those who do not know where the DRC is, if you look at Google Maps, the DRC is really the center of the world. Yeah. And here, this arrow indicates where Kinshasa is, the capital of the Democratic Republic of Congo, where most of the activities of the center are taking place. And here, far up north, this is Belgium, Leuven, and the Center for Human Genetics in Leuven. So about 14 years ago, by now, staff members from the Leuven Center for Human Genetics started to have regular missions to Kinshasa, and they were mainly driven by Professor Prosper Lukusa, who is a former collaborator in Leuven, who went back to his native country, and we accompanied him. So we engaged in teaching, education, both in the bachelor's in medicine, but also the postgraduate, mostly in pediatrics. We organized genetic clinics. And actually the aim was to get insight in the local situation. And our ultimate aim was to try and contribute to building a center for human genetics locally in Kinshasa that meets the real needs of the African population. And this by taking into account the local medical, but also social, ethical, and legal aspects into account. So we met academics, we met clinicians, so doctors, we met patients, we met researchers, but we also met policymakers locally. And this really gave us insight in how to reach this goal. But I will now give the word to Professor Lukusa, who is currently the head of the Center for Human Genetics in Kinshasa. And I think he's best placed to explain how this went along.
It's my great pleasure to welcome you to this virtual talk of the Center for Human Genetics at the University of Kinshasa, Democratic Republic of Congo. The DUC is one of the largest countries of Africa, located really centrally in this continent. The population is estimated at more than 90 million, with a very young population, 68% inheritance, less than 28. You can understand why more than 1,700,000 babies are born every year. For comparison, in Flanders, annually 60 to 70,000 babies are born. We all know the achievements of medical genetics in the last decennia in the world. There is not a single specialty in medicine where genetics is not involved anymore. Also, in DRC, patients and families are confronted with hereditary diseases and they need genetic expertise in the same way. However, until recently, no doctors were trained in clinical genetics. There were no clinical genetic services. Genetic tests were hardly available, and research in this domain was lacking. This had to change. We therefore dreamed of a center of excellence in the field of human and medical genetics in Kinshasa. The mission of this center was to provide service to the population, to perform research on genetics and domains that are a priority to the populations, and to offer teaching and education to health professionals in the teams. In this, I had the example of the Center for Human Genetics in Leuven, Nantes. I was indeed trained there, and I obtained my PhD in genetics there. Moreover, during the 1960s and 1970s, Professor Herman van Berg, founder of the Leuven Center for Human Genetics, also created a genetic center at the University of Mamy in Kinshasa. This is the Center for Human Genetics nowadays. The team consists of 10 medical doctors, of which 4 have earned their PhD in the field of genetics, while 6 others are PhD students and 1 lab technician. We also have 1 bioinformatician and 1 secretary. Thus, there is time for team building. Since our first steps, we also urgently worked through the establishment of Congolese Society for Human Genetics, which held its first successful congress in Kinshasa in May 2013, and the second one in Lumbula in May 2015. This initiative was supported in part by the free US. The Congolese Society for Human Genetics represents the genetic community from DRC and coordinates various national initiatives. It also fulfills a liaison role with the international community of genetics.
So you've heard that the mission of the Center for Human Genetics is actually threefold. One is the provision of clinical genetic services to the population, both clinics and laboratory diagnosis, education and training of medical personnel, but also providing information to the population and policymakers and research. And obviously, these three are interconnected. So the goal was to build capacity in these domains. And obviously for this, we also needed infrastructure, especially for the laboratory diagnosis aspect and research. So how to handle this? Well, our vision was to initiate research projects, because this would allow us to build capacity, to gain knowledge, and at the same time build infrastructure. And you all know you need a lot of money for this. And well, grants are not very easy to obtain, but we were all very determined. And I would like to specifically thank all our sponsors and organizations who funded our research in these past 10 years. Without this, this would not have been possible. I will now give the word to Professor Lumaka, one of the collaborators of the center, and he will explain to you the challenges of trying to build a genetics laboratory in Central Africa.
Hello, everyone. A genetic laboratory in any modern city has to meet a number of requirements to earn the trust. It is known as quality assurance system. A minimum standard included management, organization, research, documents, continued improvement and training, a clear flow of testing and reporting, external service that includes reference system and making also the system affordable for the community it is offered to. When it comes to Africa, those infrastructure are not available. We need to start really from scratch. In our case, we received a room like this one where there was nothing available to make it a laboratory. We needed to work it out from really scratch to install electricity, to install water supply, and have a freezing system because the room temperature or the environmental temperature is really high, which is not good for storing of reagents. And this is the final result we obtained. We were able to set up a laboratory that met minimum quality requirements for in terms of a room or accommodation. On the other side, there is also a struggle for equipment. Heavy equipment that you can find in a genetic laboratory in Belgium are not available for us, or they are not affordable. We were lucky with the collaboration and different projects we have developed with the real US to get some equipment that you can see here, the mini cab that allows us to do sickle cell anemia testing. My colleagues are going to dive deeper in the presentation that are coming next. We have been able to acquire from our proper funding a sequencing, benchtop sequencing machine, a new PCR machine, but they also, without the support from the government, we don't have the clearance for the custom to make those equipment deliver in a country. So these are still staying in the supplier for the moment because of the lack of the clearance from the custom. There is a trouble we are having, or we were having, for reagents supply, because there is a limited number of suppliers on the field and the prices are really expensive. So what we have done is to purchase from Belgium raw material that we can condition ourselves when it's possible so that we could have good quality reagent to be used. Training is an important part. Thanks to the collaboration with the K11, all but one of the people you can see on this photo have all been trained or are being trained partly or fully at the K11, which ensure that we have a well-trained team of people that can provide a good laboratory service. And contemporary genetics testing in Europe rely on heavy sequencing machine. The whole genome of an individual is sequenced and interpretation and done using heavy computing capacities that are not available in Africa. Instead, we have opted to start with the interpretation part, which require less heavy bioinformatic equipment, and we are also trying to provide type of testing that are needed by our community, including tests for sickle cell anemia that is going to be presented. I am going to finish my presentation with this report made by the national TV that is capturing the whole collaboration we are having with the K11 and the Vibros, and it's present a moment where a virtual equipment was received from the K11. Thank you very much.
Possible avec l'acquisition des matériels de laboratoire de génétique humaine que vient de bénéficier la faculté de médecine Sangla à l'université de Kinshasa, matériel provenant de la Belgique. Reportage de Patricia rendu par Patrick Condon. C'est dans l'université élèves en Belgique par lesquels les professeurs de Prosper Lukusa et qui composaient les les professeurs Jean-Marie, ces matériels sont destinés pour les centres de génétique humaine de l'université de Kinshasa dans le but de renforcer sa capacité de recherche des ADN et autres.
So the idea of starting with research to build capacity in an infrastructure, then we obviously needed to define good research teams. And well, obviously they need to be relevant for the Congolese population and questions that can only be answered by research locally in the community. And as for all research, it has to be in line with expertise, but also interests of the Kinshasa and Leuven teams and other collaborators. And at the onset, we defined 3 large teams. The first one is sickle cell anemia, which is a hereditary disease of the red blood cells, then oculocutaneous albinism and developmental disorders. And in what follows, it will become clear why these are important and what steps have been taken since. So we were very happy to be able to recruit young and very enthusiastic PhD students for these different projects. So let's start with sickle cell anemia. Most genetic disorders are found anywhere in the world, but sickle cell anemia is a notorious exception. As you can see here, it's most prevalent in Central Africa or Africa below the Sahara. Yeah, and really in the DRC, the incidence is very high. About 1 in 70 newborns is affected with this disease, which means about 40,000 newborns annually in the Democratic Republic of Congo. And the drama is that almost half of these children die before they reach the age of 5 years. So clearly, this shows that this disease is a very high priority for the population. And I think over 5 years ago, we obtained funding, a team project from Vlier UOS, to initiate a research project, both regarding diagnosis and treatment of patients with sickle cell anemia in the Democratic Republic of Congo. And these are the participants, and each of them will explain his part, her part in this project. And first the word is to Professor Tite Mikobi.
I'm Tite Mikobi. I'm one of the collaborators of Professor Lukusa, the head of
a human genetic laboratory. In my role within the laboratory, I deal in general hemoglobinopathies and in particular sickle cell anemia. In this field, our laboratory is the only one in Kinshasa and even in our country which carries out the molecular diagnosis of sickle cell anemia. In recent months, we have just implemented the antenatal diagnosis of sickle cell anemia by amniocentesis. Dr. Mamy Ngole, one of our students from our laboratory, will be present the technology we use. In addition of the molecular tests for sickle cell anemia, our laboratory is also equipped with a capillary electrophoresis device thanks to finding for the. This device always biological monitoring of sickle cell patients who are under treatment for hydroxyurea. In effect, hydroxyurea is the only medical treatment currently that has improved the quality of life of sickle cell patients around the world. This device makes it possible to quantify the fetal hemoglobin to access the response to treatment, because one of the effects of hydroxyurea is the synthesis of fetal hemoglobin. Currently, hemoglobin fetal is one of two genetic factors that modulate the sickle cell anemia phenotypes. We can now visit our laboratory with the different members with the respective field of research.
So now Dr. Mamy Ngole, she's a clinical biologist and she got the task to actually introduce genetic testing for sickle cell anemia in the laboratory. The sound is rather poor, so that's why we have subtitles.
Patients have to wait for around 4 days for a available diagnosis. And the link they will be spend a period to receive another treatment. Sample collection, sample transport, the DNA extraction step, and the cost of the repair. So, the big block, I will say, on painted basis, that's all since then, I received blood samples from many areas of the
Okay, now I will switch to the second part So besides this laboratory aspect, do you see this screen?
No, Professor, we don't see it.
No. Okay, let me try again. Yeah, now you should be able to see it. Okay, so obviously taking care of patients not only implies reaching a reliable diagnosis, as Dr. Ngole explained us, but also we tried to treat patients with hydroxyurea, the only treatment available today. So we have two clinical trials, one in Kinshasa for adult patients, this is by Paul Lumbula, and then another one for children in Kisantu, which is a hospital located about 120 kilometers away from Kinshasa. And this is by Gloire Mbayabo. So let's first hear the experience of Dr. Gloire Mbayabo in Kisantu.
My name is Gloire Mbayabo. I'm a pediatrician. So we conducted a study about the diagnosis and treatment by hydroxyurea of children with sickle cell anemia in the Democratic Republic of Congo. The sickle cell anemia is the most genetic disease in the world. And in the Democratic Republic of Congo, the prevalence of this disease is very high. So the prevalence of the homozygous form of sickle cell anemia varies between 1 to 2%, and the prevalence of heterozygous form is around 20%. The sickle cell anemia causes anemia, painful crisis, and susceptibility to infection. That study was conducted in Kisantu Hospital and funded by EOS. We chose Kisantu Hospital because it's a rural hospital located 120 kilometers away from Kinshasa. Also, Kisantu Hospital has a long partnership with the University of Kinshasa, University of Leuven, and University Clinic of Leuven. So we recruited 160 patients or children following in Kisantu Hospital for sickle cell anemia. That patient was detected, was confirmed, was diagnosed using an email test. But among all the patients, after DNA testing, only 136 patients was confirmed to have sickle cell anemia because DNA testing is the gold standard. It's not effective by the young age or the recent procedure. And among all the patients, all the sickle cell confirmed patients, we give hydroxyurea to the patient severely affected. To know that patient is severely affected, he has to have in the previous year at least 3 painful crises, 3 hospitalization, and 3 transfusion, and the low rate of fetal hemoglobin. And after giving hydroxyurea during 2 years, we observe the improvement of clinical feature, of clinical profile. In fact, after 2 years of treatment with hydroxyurea, we observe the decrease of the number of painful crises, the decrease of the number of transfusion, the decrease of hospitalization, and we observe also the improvement of the increase of fetal hemoglobin. So we can say that DNA, that project funded by EOS, free EOS, allow us to know that to confirm that DNA testing is the gold standard, and also hydroxyurea is important to improve the survival of sickle cell anemia children.
So that was the experience in Kisantu in children. Now we will hear Dr. Paul Lumbula, who was actually following adult patients and his view as a pediatric cardiologist.
Hi, I'm Paul Lumbula, a cardiologist. I am member of the team of genetic department of the University of Kinshasa. My work is focused on sickle cell anemia, a disease which is very common in the Democratic Republic of Congo, where the mortality is high, with the most vulnerable period being under 5 years old. This situation is now changing slowly with the improvement of socioeconomic condition, early diagnosis, and improvement of care focused on effective treatment of anemia and infection. We can then observe an increase in life expectancy in sickle cell anemia patients. However, the observed increase in life expectancy in these patients is accompanied by the increased frequency of chronic complication of sickle cell anemia, especially chronic organ damage concerning the cardiovascular system and the kidney. This organ damage is an additional vital threat for the sickle cell anemia patients. In fact, cardiovascular complications are represented by an enlargement of the left ventricle, the alteration of its pump function, and the onset of pulmonary hypertension. Thanks to the funding by VIR-US, we got the opportunity to conduct a trial with hydroxyurea, an effective treatment for sickle cell anemia approved by the FDA in the US and most of rich countries in the world. We took this opportunity to study determinant of the response to treatment with hydroxyurea in our patients, and we also study whether treatment with hydroxyurea will slow down the heart disease. Follow-up of our patients included a monthly visit for a clinical examination and follow-up of biological parameters in selected patients. At the time of this visit, patients are also refilled in medication, hydroxyurea, and we look for any side effect of this treatment. Also, the dosage of the medication are adjusted according to the patient's weight. The cardiac ultrasound was performed every 3 months for the evaluation of morphological and functional change. The evaluation of the pulmonary vascular hypertension was made through the evaluation of the tricuspid regurgitation jet velocity. When this velocity was as high or more than 2.5 meters per second, this patient was considered as at risk of presenting a pulmonary hypertension. And in the follow-up, the data, the echographic data, the initial echographic data will be compared with the final data to see if there is an improvement or a worsening of these parameters in each patient. At the end of this trial, we will be able to identify genetic factors that determine the outcome of patients in our region. Thank you for your attention.
So, as you heard, thanks to the very hard work of these talented young physicians, we gained a lot of experience on sickle cell anemia in Kinshasa and in Kisantu. They are currently collecting their data, analyzing the data. Manuscripts are being written, and I'm very confident that in the course of next years, the three of them will be able to defend their PhD thesis in Leuven. But let's now move to a second condition, oculocutaneous albinism. And again, for reasons which are not fully understood, this condition is very prevalent in sub-Saharan Africa, in contrast to most other parts of the world. And albinism means lack of pigment. And we have black pigment in our eyes. So having no pigment means that you have visual problems. Absence of pigment in the skin gives you a skin without color. And in an African situation with the very hot climate, the very sunny climate, you can imagine that they are exposed to skin complications, and especially cancer, which may occur already at a very young age and is life-threatening. However, a very peculiar aspect of oculocutaneous albinism in Central Africa is that these people really have to fight during their entire life for discrimination. Professor Leticia Mavinga, whom you can see here, is a very talented clinician and researcher. She's a pediatrician, and she set out to study genetic and clinical aspects of oculocutaneous albinism in Kinshasa. And actually, last month, she defended in Kinshasa her PhD thesis. But as you can imagine, that performing research with people with oculocutaneous albinism is not so easy. You really have to gain trust of this community. And I think Professor Leticia, she really succeeded in a wonderful way, because she put the care for people and their families with albinism central. She had a very close interaction with the patient organizations, and she has a continued engagement towards these patients. And as a proof of this continued engagement, she is now one of the main participants in a FLIR UOS joint project. It's a network for research and multidisciplinary medical care for people with oculocutaneous albinism in the DRC. And actually what we try to do there is to bring together expertise from the three main cities in the DRC, Kinshasa, Kisangani, and Lubumbashi, bring together the expertise to actually improve medical care for those people. And in addition, this will lay the foundations for further research. So last week, this joint project held a meeting in Kinshasa, which was picked up by the local television, as you can see here.
Victimes des discriminations à travers le monde, les albinos sont des personnes à part entière qui méritent l'attention et la considération de tous. L'albinisme, une maladie héréditaire, rare et non transmissible, existe dans le monde entier, indépendamment du genre et de son appartenance ethnique. Il est aujourd'hui possible en République démocratique du Congo de se faire dépister avant le mariage pour prévenir la naissance d'un albinos dont le couple a soutenu le professeur Dr Leticia Mavinga. Cette matinée scientifique de sensibilisation sur l'albinisme du 15 juin aux cliniques universitaires de Kinshasa a été riche en exposés des pédiatres, ophtalmologues et dermatologues autour du thème « Mieux connaître l'albinisme en RDC ». la présence du ministre des Personnes vivant avec handicap, Madame Irène Essambo, à cette journée scientifique, prouve à suffisance, selon elle, son souci de valoriser cette catégorie de personnes. En sa qualité de chef de service de génétique au département des sciences de base, le professeur Dr Lukusa Prosper est revenu sur la quintessence de cette journée de sensibilisation.
La journée d'ici aujourd'hui, c'est surtout approfondir les aspects scientifiques qui ne sont pas approfondis dans les forums ordinaires qu'on organise sur l'albinisme.
Le président des associations des albinos du Congo a eu le mot juste pour remercier le responsable du département de génétique humaine de la faculté de médecine qui ont vu juste en organisant cette journée qui vise à sensibiliser et à revaloriser la personne de l'albino.
So this project is really evolving wonderfully. The third main topic is that of developmental disorders. And actually, developmental disorders is a term we use to indicate congenital anomalies. For instance, children with a heart defect or a cleft lip, and intellectual disability which was formerly called mental retardation. And actually, the whole center started with the PhD from Professor Aimé Lumaka. He was the first PhD student, and you heard him before. He's now really an expert, not only in clinical genetics, but also in molecular genetics. And he gained his PhD already in 2015 on a genetic etiological study of intellectual disability in the DR Congo. His research was followed up by Dr. Gerrye Mubungu. Dr. Mubungu is currently in Leuven because next Wednesday she will defend her PhD thesis on congenital malformations and minor anomalies in Congolese newborns. And I will give her the word now.
I am Gerrye Mubungu. I am a pediatrician and medical geneticist. I work on congenital malformations and minor anomalies in Congolese newborn. Congenital anomalies are a major health problem worldwide. They are linked to the high mortality rates in the world, particularly in my country. In Central Africa, an estimated 1 in 7 children dies before the age of 5 years. For children with a congenital anomaly, life expectancy is even lower. The diagnosis and management of congenital malformation is suffering of lack of training of physicians or lack of equipment. And not everybody has access to appropriate care for congenital malformation because the cost is most of the time prohibitive and there is no reimbursement for cost of the treatment in Congo. In addition, the perception of the origin of congenital malformation is also particular because the mystical beliefs prevail. The general aim of the study was to perform research on the incidence and impact of congenital anomalies and dysmorphism in Congolese newborn. We established a network with 2 maternities located in Kinshasa where we conducted our study. We also work at the university hospital. We determine common trait of our population. We define dysmorphism as the presence of 3 or more minor anomalies. However, we observe that newborn with dysmorphism and major anomalies constitute a significant risk of mortality. This highlights the importance to evaluate dysmorphism when child is admitted to the neonatal intensive care unit, but also in the maternities. Next, we establish a reference values of the facial features for term newborn. As described previously, there is a difference between Congolese and Caucasian facial features. Given the subjectivity of evaluation of facial features, we finally evaluated an automatic tool for the analysis of facial features. However, ethnic background influences the facial expression of common genetic symbols. To optimize performance, histogene needs to take ethnicity into account. The data we obtained in the study will guide clinicians to better recognition of children with congenital malformations, as well as an improved care, leading to better survival of these children.
Okay, so based on this initial experience, we will now initiate another research project, and this will be done by Dr. Dalichika, a PhD student, currently pediatrician, and she will actually, a bit in a similar way as we did for the persons with oculocutaneous albinism, study clinical and genetic aspects in people with Down syndrome in Central Africa. The team in Kinshasa really gained a lot of expertise, which was recognized by other teams in Africa. And this is how we got involved together with Johannesburg in a project, a research project, DDD Africa, or Deciphering Developmental Disorders, which was sponsored by the NIH from the United States of America. So the idea is to perform up-to-date genetic testing, so the most advanced genetic testing by exomes, for the specialists among us, in 500 people with unexplained developmental disorder. And Dr. Prince Makay, he is actually the PhD student from Kinshasa mostly involved. So the partners in this project are Kinshasa and Johannesburg with support from Leuven, and then the Sanger Institute in Cambridge. And I will give the word to Dr. Prince Makay.
I begin to recruit patients from United States and and after that, they put the straight from our lab and our center was home to the World Congo Institute, and so the move follow my equipments, the collect contact from
Et avec ces ils peuvent faire certaines recherches
parce qu'à l'issue de recherches, de leurs examens, nous pourrions avoir un développement de compétences sur l'intégration de nos enfants. C'est quelque chose qu'il faut encourager. Encourager, nous, parents, nous encourageons. Mais il faudrait que même du point de vue de notre gouvernement, on encourage ces gens. Parce que les enfants avec un handicap, quand on est il y en a ici à
So as you can see, over the past 10 years, the Center for Human Genetics in Kinshasa really has gained a lot of expertise. And this is reflected by over 25 scientific papers in international peer-reviewed journals. And I'm confident that many more will follow. So in name of the Kinshasa team, I would like to thank you for your attention. And if ever you are in Central Africa, know that you are welcome to visit the Center for Human Genetics at the University of Kinshasa. I thank you for your attention.
Thank you so much, Professor Devriendt. This was a very interesting and entertaining presentation. Thank you very much for that. I see that you invested a lot of time in it. So we really appreciate this. Also, thanks to your Congolese colleagues, because in the end, you know, those are the ones who are also putting into practice what has been researched. We do have some questions, as I invited people at the start of this community talk to post the questions in the chat. And I must say that Nimron Sekanabo was very active in the chat. So I would like, because he gave a lot of comments, so I would like to invite him to take the floor and to rephrase what he has been written in the chat. So Nimron Sekanabo, please join us and raise your questions again, if you're still there. Let me check. Oh, I think you already. Yeah, no, Nimron, you should be there. I can see you in the participant list. Maybe while Nimron is checking his microphone, I would like to ask Anneleen Verhasselt, who was actually also asking whether you have been collaborating with statisticians. Professor Devriendt, can you answer that?
Yeah, maybe one of my collaborators can answer this.
Hello.
Yeah, Nimron, just 2 seconds. We are now. We'll come back to you in a minute. First, okay. Another question.
Okay.
Yes, Koen, who do you think who should answer? Just point someone.
Aimé, are you there?
Yes, I'm here. Sorry. I didn't catch the question because of interferences. If you could repeat the question.
Well, the question is actually how our interaction with statisticians is.
Yeah, very interesting question. And this is one of the points of struggle that we are having at the moment. We have produced so many data that we have reached a point where statistical analysis has become very critical. For the moment, we are collaborating with one colleague locally, but we are also engaging with the team in Leuven, because the type of statistics that are commonly applied on the field are mostly oriented to infectious diseases. It's not really into what we are doing. So it's now the time for us to really start training people through this channel to become familiar treating genetic data. It's a completely different word. They have the background, but they are not specialized enough to be able to treat the data. Genetic data, I mean.
Thank you, sir. Professor Verhasselt, is that a satisfying answer, or do you have more questions?
But are you also working with people in Leuven, the statisticians in Leuven, like people from Biostat or Elstat. Maybe it's a question for Professor Devriendt.
No, actually not yet. For the part on the newborns, we had a very close interaction with Mathieu Roelands, because it's about biometry, and this is he's really an expert in this domain. But obviously, if we would be very happy to work with your group if you're interested to join us.
I'm from Hasselt University, but it doesn't matter. It doesn't matter.
It doesn't matter. Absolutely.
No, because I have myself a project in Indonesia. It's within statistics, right? And we're also there training the statisticians on specific subjects. So I was wondering whether in your projects you also have this kind of training aspect in statistics, because I see you collect a lot of data, and I was just wondering, do you get all the information out of your data? Do you have the appropriate or the knowledge to apply the appropriate statistical techniques to analyze them?
To be honest, probably not. So we usually work together with people locally, yeah. Probably in the next phase of our projects, we will need to get more attention to this aspect. I completely agree with you. Yeah.
Thank you very much, Professor Verhofstadt. Actually, you highlighted some very important elements within the cooperation of FLIR-US. That is, of course, cooperation with our partner universities in our 17 partner countries, but also on Flemish side, we really encourage people to work together over the university boundaries. So Hasselt working together with Leuven, that sounds like music to me, you know. So please, you're all invited to work together, because in the end, you know, the problems that we are faced with are so huge, you cannot solve them alone. So please feel free and take up contact, of course. And also it would be nice, for example, to start some cooperation between our Congolese partners and our Indonesian partners. Imagine that would be very interesting to exchange ideas and exchange expertise. Okay, I would like to come back to Sekanabo. I saw that Professor Sekanabo, are you there? He's there. Please, sir.
Shoot. I'm Dr. Nimron Sekanabo. I'm not a professor. I hope to be one.
Please, ask your question, sir.
In the future, I applied for, whether it is good or advisable to put these patients of sickle cell on hydroxyurea, especially because in Uganda, I work in Uganda, Western Uganda, near the border, one of the border districts, but I've put 2 patients on hydroxyurea. One challenge, they can't afford the drug, and 2, we can't investigate them because our hospital is a low-level hospital. So I keep wondering, should we continue hydroxyurea? Should we stop it? But the one patient who was almost dying, I put him on hydroxyurea and he's doing well now. He's doing a bit much better. I don't have any data. I don't have any collaboration. This is my first time to interact with people doing genetic work on sickle cell. I'm really happy to be here, but I don't know, should we continue? Should we stop? They can't afford, we can't do LFTs, we can't investigate them. So I'm just there. Thank you.
Thank you very much, sir. Actually, this is to me, that's a straight question to our Congolese friends. So actually, Congolese colleagues, your expertise is asked in Uganda. Who can answer this, Dr. Sekanabo?
Maybe first Paul, Lumbula, and then Gloire. You can actually give like some comments on your experience, but also on the long-term engagement and the problems you face. Paul, are you there?
Okay, I'm there, Koen.
Yeah.
Okay, thank you for the question. The only comment I can do is that the work we are performing now is an initial work to see if in our settings we are able to conduct such treatment. But afterward, with data we will get, it will be possible to see if we can put them on treatment for a long time. But there is a serious issue concerning the refile in medication, because the medication have a cost, and all patients did not usually have a accessibility to medication. So that we are making a reflection now to see in which way we can help our patients to be refiled continuously in hydroxyurea. So it is a realistic issue, and we have to find some solution for that.
Okay, thank you very much.
So Gloire, Gloire, maybe you can comment from your experience.
I can comment. First of all, I would like to know about Dr. Sekanabo, which was the age of the patient, which was the dose of hydroxyurea he gave to the patient. So that's the question. But normally, after 2 years of trial, we saw that
I think we're going in very much detail here. I'm already lost, I must say, I must admit.
Use clinical events and improve also clinical features. So, Dr. Sekanabo is, are you hearing me?
Yeah, Gloire, I suggest this is quite detailed, that maybe you get in contact with each other, right?
Yeah. You have to contact us. I write my email here. He can contact us and to exchange with him.
Excellent.
Yeah, because we have many things to respect before to put on the hydroxyurea. We have also to follow clinical and biological profile of that patient when you put on the hydroxyurea.
I just wanted to make a general comment. If we look at the question from our colleagues from Uganda, I would say that the answer would be a straight yes, okay, because this is a highly prevalent disease in our setting, and majority of children, affected children, they are dying before the age of 5 years. So there is an economical impact in terms of on the country. Because this is affecting the child, you have young people dying, they cannot contribute economically, and at the same time they are often sick, they are going to the hospital, which is further depriving the economic resources from the family. So there is the need to put under this type of treatment. Whether this can be sustained on the longer term, it requires the involvement from the government and other organizations. This is another question, but should we put them? Yes, because of the reason that I have made, not scientific reason, economical reason, and both on the child and on the family, we should put them on treatment.
Thank you very much, everybody. Actually, we already reached our first goal of this community talk, namely creating a network, putting people into touch with each other, and actually I saw in the chat that all involved partners of this discussion actually put already their emails. So please get in touch with each other and help each other. That's what we are here for, actually. It's already past noon here in Belgium. I don't know whether there are any questions left. If not, I would like to close it. First time, second time, third time, just unmute yourself and ask a question if you have any. If not, I suggest we stop here. Professor Devriendt, I would like to thank you a lot. It was very interesting. I saw that you invest a lot of time in the presentation and also in the films, in the movies. I would like to thank your colleagues a lot as well. All of you, continue the good work. And also check our website on a regular basis, because we will launch new calls for projects very soon. So please stay in touch. And if you have any questions, there is one email address. It's community.talks@vlierios.be. So please post any questions you have on that website, and we will come back to you as soon as possible. As I said in the introduction, usually we have this type of community talks by the end of each month. Next month we will have a break, so we will get out. But in August we will be back, and then we will go to Ecuador with people from Ghent University, with Hans Verbeek, who is doing some research on forestry in the western part of Ecuador. So as you can see, we are everywhere, and we are active in any discipline. So I invite you again. I would like to thank you, all of the audience here, for joining us with this community talk. And again, thanks to our colleagues in Leuven and in Congo. Thank you very much, and hope to see you again, and looking forward to the final results.
Okay.
Thank you all. Very nice presentations. Thanks a lot.
Thank you. Bye-bye.
Thank you. Bye-bye.
Bye.